Hello, good afternoon. My name is Ahmed Madgy. I am a consultant cardiologist from the National Heart Institute in Cairo. And I'm here in C3, one of the most important intervention meetings in the States, and it's a global meeting. And it's my honor and pleasure to have with me in this interview on my right side, Professor David Erlinge. He is a professor of cardiology from Lund University, Sweden. And on my left side, Professor Stefan Achenbach. He is chairman of cardiology in Erlangen in Germany. And Professor Peter Clemmensen, he is professor of cardiology in Hamburg, Germany. So, welcome, my friends and colleagues.
It's a pleasure to be
Thank
here.
you. Yeah, great to be here.
And so today, 2 hours ago, we had a very important session. So it was on the, it's named the European Collaborative Session. It was focusing on many important items in the cardiology and intervention. And we had 3 elegant talks by my colleagues and professors here. And so would you tell us, Professor David Erlinge, about what was your objectives of your study and of your lecture, please?
So I talked about using physiology to assess coronary arteries, and I recapitulated the FFR studies, DEFER, FAME, and FAME2, and what we learned from them, and how physiology can help us to stent the correct lesions and defer and avoid stenting the wrong lesions. Then I continued to tell about the relatively new method of using IFR, which is another physiological assessment where you don't need adenosine. And we have shown in 2 large trials that IFR is equal to FFR in selecting patients and in outcome of patients where you have physiology-based PCI. And the good thing could be, because FFR are good, which is very good, still is only used in 8% of the angiographies in the world. And maybe with IFR, which is simpler, faster, cheaper, that could spread and increase the use of physiology-based stenting.
And what is the status in your cath lab? What is the penetration of IFR and FFR in your cath lab?
We are about 25% use of IFR or FFR, which we say is too little, but nobody knows exactly where we should be.
So you recommend that in certain cases, complex cases, in the, I mean, which kinds of patients which you recommend that this kind of flow measurements should be taken?
First of all, I think you need a period where you're using a lot, because we actually have learned that long lesions in the LAD is usually significant, and short osteostenosis on branches are usually not significant. So just by using it a lot during a period, you will have learned much about what you should treat with PCI. I'm not exactly sure what the right percentage is. Maybe 30–35%.
So what happens if you geographically find a region that looks significant, but when you do FFR or IFR, it is not reaching this level?
Well, sometimes it's very clear.
Yeah.
If it's 1.0, then it's not significant,
Yeah.
and I will leave it.
Yeah.
And sometimes it's very significant, and of course I will treat it. But very often you end up in the borderline zone.
Okay.
And around 0.80 for FFR. You can 0.84 or 0.77. Which one, is that significant? Is there a difference? I don't think so. I think it's a gray zone. And you need to discuss with the patient, put the whole clinical picture in play before you make a decision.
So you add the common sense and the experience of cardiologists.
Yeah.
So
We
thank
still
you.
need that.
Yeah. So Professor Stefan Achenbach, one of the world experts in imaging, so you give us a very important lecture. Would you tell us about the objectives of your presentation?
Yes, certainly, it's a pleasure. It was first of all great to be here and be part of this fantastic meeting with very good educational sessions all day. And the session that we was really on PCI and how to improve PCI. This is what my colleagues and I were speaking about. And I was tasked to speak about imaging and what imaging can do for interventions. I talked about CT, OCT, and IVUS. And for CT, computed tomography, I have to say that the main focus for computed tomography is diagnosis, especially ruling out disease. And there's a very small potential role in the context of intervention, mainly as far as chronic total occlusions are concerned. There is some data that by CT, looking at the CTO, you can predict the likelihood that the CTO can be successfully reopened. That's the role of CT basically in the context of intervention. For OCT and IVUS, it's completely different. That's really where if you think about performing PCI, if you think about optimizing PCI, you can use OCT and IVUS to verify the type of the lesion, the length of the lesion. After the device has been deployed, you can verify the quality of device deployment, malposition, under expansion, all of these things. Interestingly, even though we assume that this will help a lot, it has been very difficult to prove that using intracoronary imaging, IVUS and OCT actually improves outcome. For IVUS, there's a bit of randomized data in complex lesions, such as left main lesions, that the use of IVUS will be beneficial, reduce outcomes, but most of this data was generated many years ago, where the stents are not the same quality as we have today. And for OCT, interestingly, it has not been possible to show so far that the use of OCT will improve downstream events. There is a large trial underway, as most of us know, the Illumian 4 trial, which in more than 1,000 patients will try to show that OCT helps improve outcomes, but so far it has not been shown. So the general consensus is that it's not mandatory to perform IVUS and OCT, but in complex lesions, such as left main and other complex lesions, it's probably beneficial. And also in lesions where we have to treat instant restenosis, it's probably beneficial, but no hard data exists. If ever there's an unclear angiogram, if you have an angiogram and you don't know really what you see, that's also when you should generously think about using intracoronary imaging, but it's not mandatory.
So you consider all these armamentarium or these tools, they are additive and not competitive.
Mm-hmm.
And so each one will carry on to bring more information about the diagnosis.
Oh yeah, certainly. Clearly, I mean, CT on one hand is different from OCT and IVUS. And to some extent, OCT and IVUS are competitive because you can use them both to assess, for example, device deployment. If you want to learn more about your lesion, plaque volume and these kinds of things, IVUS is probably better. If you want to learn more about device deployment, you can see the struts much more accurately by OCT, but in a way they overlap as far as their clinical utility is concerned.
So in Erlinge, who are the patients who you send to do for them CT angio? Are you following the guidelines only in certain category of patients, or what is in your daily practice, what you do?
Oh yeah, in Erlangen very clearly, CT is to diagnose and rule out coronary stenosis, especially when pretest likelihood is low. We like to keep patients without stenosis out of the cath lab. In the context of PCI, we use CT for every chronic total occlusion to gain more information, but I would not consider this absolutely mandatory. It's nice to have, but not absolutely necessary. IVUS and OCT we use a lot for our more complex interventions, always in left main interventions, and in that case usually IVUS, because the image quality of OCT can be challenging in the left main because you have to flush the lumen with contrast, and that's sometimes difficult. For all other vessel segments, we will typically use OCT rather than IVUS.
And the CTO intervention guided by CT, are you also a fan of this idea and you are using this in your practice?
Yeah. As I said, we're using this, but it has been difficult to prove definitely that it improves outcome. What we have shown is that image fusion between CT and invasive angiography helps us save contrast agent and radiation because we can always find the best projection. But that's the only thing that we could prove so far. Not outcome, not recanalization rate, only the use of contrast and radiation has been decreased by adding the CT. But of course, every single center has relatively small data sets, and by combining larger data sets and making this multi-center, maybe at some point we'll be able to prove something.
This is the first time for you in the C3.
It's my first time, but not my last time, I'm sure. I'm impressed by the meeting and the quality and the spirit of education that we find here.
And being one of the board of the European Society and one of the leaders there, how do you think future collaboration with such intervention meeting, and it's how do you see the collaboration would be in the next few years?
Well, the European Society of Cardiology very clearly sees the need for education. Education is absolutely important that we can fulfill our mission, which is to reduce the burden of cardiovascular disease. We have to make sure that physicians are well educated. And the more practical and the closer to clinical practice education is, the more useful I think it is for our physicians and then downstream for the patients. So any form of collaboration that can improve this is always welcome.
Yeah, that's very important. The world is now it's a global village. I mean, everybody is collaborating, and each of us we all have the same target and the same objectives to improve our the fellows' education and to improve the cardiology practice. All these things are very important.
Couldn't agree more. Absolutely.
And Peter Clemmensen, my friend, and you addressed the myocardial revascularization.
Exactly.
And a new myocardial revascularization guidelines will be available within 2 months. And so, how do you see? Do you follow the book, or do you follow the sense, or what did you address in your talk today? And how do you see the difference between the guidelines that had been written in 2014 and 2018?
Well, thank you very much. First of all, I would like to also thank you for the invitation, and also being a newcomer here at this meeting. I'm impressed with the quality of the program, and congratulations to you and Raj Dave for an excellent organization. Well, back to your question, as you said, I think importantly we have to recognize that even though the next guideline is probably going to encompass more than 1,000 papers being referenced, my guess is there will still be a lot of C recommendation. So in difficult patient subset that are not included in large clinical trials, some have been mentioned by my colleagues here already, will still need a lot of doctoring. So I think that's an important prediction for the future. Then I argued actually that I think we have, after 2014, so the last 4 or 5 years, we have actually changed our practice based on the guideline that surfaced in 2014. I think important examples, we cannot mention everything, is that we now do not routinely in STEMI patients do thrombectomy in all patients. That was a big change from the previous guideline. Others is that we use different antithrombotics and in a different constellation. Again, details are very difficult to go into. But like I mentioned also, the guideline in 2014 regarding antithrombotics, the combination of antiplatelet therapy and anticoagulation has actually been bypassed by an update on dual antiplatelet treatment that came out from the ESC last year. And then importantly, looking forward, amazing how much science comes out in revascularization. So I think new assets will be actually on left main interventions, where we have new trials have emerged since the last guideline. We will have new data on CTOs in chronic total occlusions in patients with chronic ischemic heart disease. And I think fusion imaging might also play a bigger role. These are sort of some of the very big things. And of course, extremely important, we will, after the culprit shock trial that was published recently, we will probably move away from a recommendation that we have to attack every lesion that we see in patients who presents with shock and have either STEMI or non-STEMI. I think these are sort of the big things.
So do you think that the last guidelines for the STEMI by European Society of Cardiology, and then the culprit shock trial came after that? So you expect that in the new guidelines that is coming shortly, then this had an impact on the ideas and on the recommendations that will come?
Certainly, and I think you have to recognize one of the advantages of the ESC flow of guidelines is actually that you had updates on parts of revascularization in the STEMI guidelines 2017 compared to the revascularization guidelines 2014, and then again after the revascularization guidelines coming out in 2018 in Munich. We will again see probably adjustments when the next non-STE guideline and stable coronary artery disease, if such a guideline should come up in the future. So there will be adjustments, every year or every other year, small details as we have new evidence.
So I will ask each one of you the same question. What do you think, the intervention cardiology and cardiology in general had reached far horizons, at least in the past 10 years. And so what do you think that is still lacking, and in your dreams, you want this to be accomplished too?
Well, one area that we still have no treatment for is reperfusion injury. We can open the vessel, but we still get a large injury when we open the vessel. And still we have no treatment that works for that. Maybe hypothermia is one, maybe some comes up with some anti-inflammatory drugs, and that can help us with that.
Do you have some studies in Lund on this area?
Yeah,
of course, hypothermia, of course.
We've done a lot of pig studies and evaluated things. We have done hypothermia studies, rapid MIs and chill MI, and now we are participating in a large study in Europe. Hopefully we'll have some effect.
And for you, Stephen?
I think we still have a lot to learn. We're trying to tell ourselves that they know everything, but we really don't. I think it's still very difficult to identify the lesions that need treatment, not only to avoid ischemia, but also to avoid downstream events such as plaque rupture. So I think it remains difficult even though we have FFR. And then after we have placed the stent, there's still so much that we need to do. For example, how good does the FFR have to be after we place the stent? How far should we go? And also downstream treatment, our battle with dual antiplatelet therapy. Should it be 12 months? Should it be less? Should it be more? In which patient should it be less? In which patients should it be more? I think there's a lot of uncertainty there, and we need to learn a lot more. It's going to remain very interesting, the field.
Peter?
Well, my dream is, first I'll postulate that, if in the war that is going on regarding patients with stable coronary artery disease, to intervene or not to intervene, I really hope that war or battle would be put to rest. And I think I would postulate then that if you look at the development of case fatality rates over the last 25, 40 years, if we had done harm with all the stents that were put in, we would not see this tremendous decrease in cardiovascular mortality. But that needs to be proven. So I think a vision could be that we do a pivotal trial in stable CAD with the newest stent, the best guiding catheters and wires, and once and for all put this crazy, so to speak, very emotional war to rest.
And being from a developing country and we still have heart attacks, we call it epidemic, and so my dream is to stop these epidemics, to work more on risk factor intervention, and maybe valvular plaque, how to predict, how to prevent people who look very healthy and then they suddenly drop and die. And so we hope, all of us as consultants and as scientists, that we can improve the world, at least in medicine. And this was a fantastic session, and it's a very interesting interview. And I welcome you all for coming this long distance to share in C3. C3 is always welcoming you, and you will be always our faculty, and it was our pleasure. And on behalf of Raj Davi, the chair of the meeting and the board of the meeting, we welcome you, and we hope to see you next year. Thank you very much.
Thank you so much.
It was a pleasure
Looking
to be
forward
here.
to coming back.
Yeah. Thank you.